Thank you, Sridhar. There is a small change, sir, because the international live transmission is coming up. We'll have the live case first, and I requested Akasaka to deliver his talk after the live case. So I request, you can continue. I request the chairpersons for this session, Dr. Sushil, and in place of Saurabh, Dr. Ajay Kirtan, also to join the panel. You can continue, sir, before. Then other panelists, Dr. Shantanu Guha, is he come? Dr. Saumitra Kumar, please join. And other moderators, Dr. Pramod Joshi, B.L. Agarwal, Rajiv Bharadwaj, Parminder Singh, Sanjeev Sharma, Hariram, please come onto the stage. We have international live transmission coming up from Antonio Colombo. We are very eager to watch him. They always do a wonderful job. And afterwards, we have a lunch and then tower lectures. But immediately after the case, we'll have Akasaka deliver his talk on imaging. Over to you, Dr. Sushil, to take over. I think we are having pictures from Italy. Over to you.
Hey Azim, hey Antonio, so nice to see you people, and we're great. We have a very excited hall waiting to see what you have to present.
Can we ask a couple questions, Antonio, real quick? Can you hear us? So Impella is just being launched in India. So the choice of Impella versus balloon pump, do you base it on hemodynamics at all? Is it the overall EF? Did you look at the right heart pressures? How do you make that decision? And this is the CP with 4-liter support, or?
Yeah, 3.5. He's got.
Yeah, okay.
Yeah, it's interesting. Yeah.
Sure, of course.
Yeah, don't let us slow you down. Yeah, especially from the radial approach, especially with radial subclavian tortuosity, this can be pretty useful to be able to get it up this way.
What about orbital atherectomy in a scenario like this versus rotational? Any difference, benefit? Are they equal, or is it?
Yeah, I think the challenge for this with orbital is because it's at the ostium, that can be an issue. But go ahead, Antonio. And you like super high speed. We can see the console, it's 220. It's okay, you're transmitting to Asia, it's okay to go 220. Yeah, no, we rarely would use the 2.5 because you really only save one French size with the access. The other thing too is that, I guess I grew up watching folks like Antonio do these cases with balloon pumps, but I have to tell you, it can be done, but it's just so much calmer, and I think this speaks to why you said in the last 6 months you've kind of converted this way. It's just so much calmer if you actually use full support like this. That I think, for me, it would be a CP, pretty straightforward answer to that question.
And I think the French size is not much. It's the cost difference potentially.
Yeah, the cost is $5,000 different, I think. Yeah. So in the U.S., it tends to be less of an issue. Okay. Yep.
I think if you're doing with the balloon pump, you just have to be a lot more cautious. Shorter runs, pre-treating for blood pressure, things like that.
Disengaging the guide.
Yeah.
Yeah.
The problem in these cases with any of these balloon pump without support is if you get into that little bit of ischemic spiral, it is hard to reverse quickly, so.
Yeah. Yeah, but at least with the slender, I mean, still spasm. It looks good.
Looks pretty good.
Yeah. So tell us, Antonio, how do you decide when you're going to rotoblade the circumflex? Because this always comes up. So Sheila and I actually had this discussion just about a week or two ago. You'd have to pull the LED wire, but yet there's calcium in the circ. This one doesn't look that bad. Are you thinking not to rotoblade the circumflex? And you're hydroplaning. So, Antonio, one thing that you'll like, a trick that you'll like is that for this step, if you put a wiggle wire down, you don't have to hydroplane it or trap it, because the wiggle wire stays anchored distally and you can just remove the microcatheter without hydroplaning or trapping. Yep.
Yeah, no, I agree. I would say maybe just barely into the proximal edge of the stent. And are you going to IVUS after this dilatation, or what is your plan? Yeah. So I agree. I would just dilate to there and then IVUS.
So this is an important step just to protect the circumflex as you're going to stent across it. And then the other step too that sometimes you see omitted is the non-compliant balloon in the vessel that has been rotobladed or atherectomized. Very, very important, because if you don't see it expand, then Antonio will go back with a bigger burr. But in this case, I don't think he's going to need to. I think it's going to expand. That's nice.
That seems to open nicely.
So again, this is the difference between the Impella versus others, is he can go up and stay up a little bit and then come down. I think with, yeah, see the pressure there?
Yeah.
With
So-
a balloon pump or without it, this would be a lot more up, down, up, down.
So, I mean, the pulsatility changes, but yeah.
Yeah. So look at that blood pressure tracing in the upper left. You can see. Yeah, you could, I think showing us once is good. Yep. There it comes.
Yeah, now you see the pulsatility coming back. Yeah.
No, and Antonio, the comment you made about the no reflow is an important one too, because of decompression. Theoretically, the perfusion pressure to the ventricle is better than if you did not have an active VAD in the ventricle.
One issue that came up, have you had to give any pressor support? No. Actually, one issue that came up last week, we were doing a case with it was an AS patient. We had done a BAV, we put an Impella, and it was a left main LAD PCI. There was intermediate lesion. What happens to IFR or physiologic assessment when you have an Impella in? And we were debating that and whether it was valid or not. Ajay or Azim, Antonio, do you guys have any thoughts?
It's not been well validated. The FFR should theoretically work, but you wouldn't want to give adenosine typically, so you can try doing IFR. I think in general, if you have the Impella in, then probably I would use imaging to know. That looks great. And we didn't talk about the bifurcation. What are your plans for the bifurcation? IVUS first and then figure it out? Yep. So that's very impressive. Everybody see the blood pressure tracing. Yeah.
The patient is sedated but awake? Is the patient feeling this at all? Are they, when the pressure goes down, are there any symptoms?
Bene. Yeah, I think so.
So your plan is to dilate the circ, but and if it looks okay, just to do a one-stent strategy still?
He's going back and forth.
Okay.
Yeah. Yeah, so even the circ dilation, the blood pressure comes down. Yeah, it still comes down. Looks better. That looks
Actually, it looks
pretty
nice.
good. Pretty good.
Antonio, you're talking about 20 years ago. You were just doing before stents. You have a nice dissection in the LAD, which would have been a success back then, right? That was the goal. You were trying to create those dissections.
That's interesting. The other thing that will come up is we had a whole left main session this morning, and there was a lot of emphasis on the imaging. And I think at this point, you know what stent size it's going to be. You just want to optimize it post. I don't think you need to do a diagnostic at this point and waste time.
I mean, the one caveat though is if you're going to put a 3.0 stent in the LAD, then I think you need to do imaging before to make sure that you don't put the 3.0 stent. And I think there are a lot of times that undersized stents can be placed, and obviously there's different populations, different sizing, but
Right.
you know, in the Prox LED, if it's going to be a 3.0.
Yeah, I think so. You have to come all the way back. That looks good. That looks good. Now you didn't mention the, Yep. Yeah, it looks great. Can you show us the IVUS? We just lost the IVUS image. There we go. Yep. Yeah, I think this all looks good. You may just have to pot the left main. Oh, very
That's
nice.
This is a 3.5 balloon?
So you know what? What's a little interesting is I think you've preconditioned him a little bit now too, because he's tolerating the inflations a little bit better. So maybe we'll get a show of hands from the audience. How many here, raise your hand if you think that the circumflex is going to look good. Raise your hand if you think that he's going to need to stent the circumflex. All right, so a little bit more for stenting than otherwise, but let's see. So especially because he has spasm in the wrist, he knows the guide is going to be a challenge. You always want to keep that jailed wire down the circumflex. It's a good marker, but it also can anchor the guide in, especially if the guide doesn't have good support when he tries to cross back into the circumflex. Yeah. New one.
But with that jailed wire, the guides get pushed to one side as well, and making it difficult to exit in the middle of the stent because the guide's not in the center of the stent, right?
So that technique he just used to wire side branches is really important to learn. Basically, when he gets it, it starts prolapsing a little bit. The typical tendency for most fellows is to then advance it, and it will prolapse down the LAD. What he then does is he gently brings it back and turns it ever so slightly, and then it goes down the circumflex. So when you see it catch, that's when you pull it back, and that's how these side branches often can get wired. That crosses
Crossed
nicely.
easily, yeah. This is not a drug-coated balloon. This is just a regular balloon?
Yeah, 3-0 though. Looks good. Yeah, it expands nicely. Now, Azim, I saw in the presentation there was MR. It's moderate to severe, or severe, and it's all functional. Is that correct? Yeah. Pretty good.
I mean, that looks pretty good.
It looks pretty good. I mean, the AV groove branch is a little pinched, but you know, the OM is bigger. So you're going back with this is the and it delivers well? Yeah, obviously it does. Maybe not.
So do you have to kiss again because if you're pulling back across?
I don't know.
Yeah.
Yeah, and that happens even in 7. It can happen, especially in the left main.
it's interesting. Is it getting hung up on that other balloon, or?
Yeah, maybe those wires are crossed.
Yeah.
There he goes.
Yeah.
That DB is a 30, or how long is the drug-eluting balloon? Yeah, I think that's true. I mean, there is some smaller data that suggests that. I mean, it's not that paper that was published in Circ Research is relatively small, and there's imbalances between the groups. But it definitely, I mean, if you don't have hemodynamic perturbation, you don't have to give neosynephrine. You know, that's got to be better. That looks great.
How much contrast have you used so far? So in terms of doing the right, you've been discussing the RCA. What are your thoughts?
It looks good. Yeah, it looks great. Yeah. Yeah, that looks really, really good.
Yeah.
You're talking about the ostium of the left main? No, on the IVUS there was an eccentric calcific plaque where if on the IVUS you could see it. But I'm sure your area is fantastic there. See, it's that eccentric calcific shelf there.
Yeah.
Yeah. Nice. Now, the one thing that can be sometimes challenging is with the impella and the positioning of the impella, it can sometimes impede your ability to get into the right coronary artery and sometimes requires manipulation up and down to be able to do it. But I think you'll be able to do it. And if you go 6 French, you'll avoid the spasm. The decision to stage versus not is always one that comes up, but Antonio said it while he has the impella in. As long as the contrast situation is controlled, you can use that to your advantage. Otherwise, the EF is still going to be low, and then when you come back for the right, if something happens, you don't have the support, and you don't want to use the device twice.
But if you do come back, it would not be the sole remaining vessel at
Yeah,
that point, so you could
that's right.
argue balloon pump support at that point as well.
Or nothing.
Or nothing, yeah.
Yeah, very calcified. Yeah, that looks like it. Yeah, you got to rotoblade that. So while the microcatheters are more expensive, I think for these types of cases, they're so invaluable because you can't torque beyond the calcium otherwise. And over-the-wire balloons are just not, I mean, you can use them, but they just don't have the same performance characteristics.
Do you have any hesitation about rota at the ostium? And when you do rota at the ostium, your wire choice is still the floppy? Mm-hmm.
Yeah, Antonio, you've been doing this transmission to here for a long time, and we really appreciate all the teaching and learning that we can get out of this. So thanks so much. I don't know if we're going to get cut in the middle, but if we do, it's a fantastic, fantastic demonstration. Very, very tough case with total calm, able to revascularize completely this patient.
More.
Okay.
Finish RC.
Okay.
Yeah.
So Azim, Antonio, we have another 5-10 minutes to see where this goes with the RCA, so take your time. Just curious. Wait, so where are you going to stop rotorblading? You're going to go to that mid RV branch, or? Yeah.
Yeah, just to the mid, I think.
Yeah.
Yeah, just the.
I would just go to the mid RCA branch. Yeah. No.
I wonder, have you ever seen or had the burr onto the impella? Because they look pretty close. Have you ever seen the burr interact with the impella device for this osteo-right type of case?
No. You said,
No.
Have you seen it? No.
No. It's appearing to me the way the two look so close together. We have not seen
it. For the audience, can you also just explain what do you do differently for osteo lesions? I mean, in terms of coaxiality or what you're doing, is there anything different that you're looking at? Any concerns you have specifically here?
So you're advancing the system there?
Yes. Okay, thank you.
Did you run out of length there, Antonio, or you have enough length? Can you show his hands? Show his hands from the other side? Yeah. Yeah. And Azim is you're defeating the break, right? Yeah. The wire to spin. Yeah.
So we have about 3 or 4 minutes left here, so. No, you, obviously it's going to take a little, all right. No rush. It's going to take longer than that. It's an impressive revascularization effort in this gentleman.
Yeah, it looks good. Yeah, very nice.
Thank you again. Thanks for a wonderful
guys.
transmission, Azim,
Really,
Antonio,
really
and the team.
fantastic. That's great
Thank you.
stuff.
So we're going to move on to our last